Good afternoon. Thank you for joining us for our commissioning strategic update. My name is Phoebe James, and I'm a Professional Development Officer with the Hunter New England and Central Coast Primary Health Network. Before we begin, I would like to acknowledge the traditional custodians of the lands that I live and work on. For me here in Newcastle, it's the Wabakal and Worimi land, and pay my respects to elders past, present, and any First Nations people joining us today. I just wanted to mention also that this session is being recorded. Before we dive in, just a quick note on questions. When you registered, we invited you to submit questions in advance so we could prepare thoughtful responses. We are happy for you to enter any questions into the chat function, but we may not get to them today, but more than happy to collate responses and respond to you. It is now my pleasure to introduce Richard Nankervis, the CEO of the Hunter New England and Central Coast Primary Health Network. Thank you, Richard.
Thanks, Phoebe, and thanks so much for that introduction. Here in our Newcastle office with me, Catherine Turner, Executive Manager for Commissioning, and Amanda Martin, who's our Manager of Commission Services, who you can see on screen as well. We've got about 40 minutes together as part of a CEO commissioning strategic update. The team thought it might be nice to try this in a lunch and learn type of format, so we'll give that a go and hope that it provides you with some useful information to help you in your commissioning work and us working in partnership. So that's the intent. Thanks, Phoebe. We'll go to the next slide. As Phoebe has done, I will also acknowledge the traditional custodians of the lands that we're meeting on today. I'd like to acknowledge the connection to culture, the land, the seas, the skies, the waterways of First Nations people, and pay my respects to elders past and present, and to any First Nations people who are joining us today. Thanks, Phoebe. We'll go to the next slide. There are a few things that we'll work through today in this. One will be a strategic update around the PHN strategic plan and vision. Also, we'll talk a little bit about the commissioning competency review process that the PHN has been through, some of the key things that we are working on, and some of the key things that are progressing. We'll talk about two possibly newish pieces of work for you. One is the commissioning relationship matrix, and the other is the cultural self-assessment. And we'll look ahead towards 2026 a little bit as well. So there's some of the key things that we will focus on today. And then at the end, we will cover your questions that you've sent through, and if time, a couple that you send through during the session. So that's the plan. Thanks, Phoebe. We'll go to the next slide. So a few things to say about the PHN strategic plan. It's on our website. There's a plan on a page version, which you can see on the slide. There's also a long version of the strategic plan. It goes from 2023 to 2028. It is an ambitious plan. It covers a few things that I'll come back to in a minute, but there are two key strategic challenges in it. One is enhancing the primary care workforce and incorporating digitally assisted services. And the second is demonstrating exceptional commissioning through leadership and performance. So they're our key strategic challenges that we are trying to tackle. They're probably not complete surprises to you. There are some ambitions that we have and key areas of focus within those areas. They include stabilising and enhancing the primary care workforce, improving equity of access to primary care through digitally incorporated services, improving health access for priority groups, maximising funding for the primary care sector in our region, noting that when we refer to primary care, we see commission services as essential components in the primary care sector, working alongside general practices, allied health and community pharmacies, and that we will demonstrate exceptional value for money in our commissioning of health services. So hopefully through what I talk through, you'll see some line of sight between the strategic plan and what we're doing. We'll go to next slide. Thanks, Phoebe. A couple of things that I'm just going to draw out of the strategic plan, and I'll come back to a little bit further as we talk through this session. First is that we've set a purpose for the PHN of increasing equity of access to primary care services. That's an important one for us because we are increasingly looking to focus our commissioning towards those groups in the community that need services most. I'll come back to that a little further. We have a long-term goal of access to timely and high-quality face-to-face or virtual primary care for every person in the region through needs-based world-class commissioning. And we have our vision, which is healthy people and healthy communities, but also a set of values that underpin our behaviours as a team and the way that we like to operate as a PHN. Now, we've had the current strategic plan for a couple of years, so we're not quite halfway through, but getting close to it. And we're trying to monitor how we're tracking against the strategic plan. There are a few things that we have been doing. Some of those are absolutely our commissioning work, and some of those are part of our primary care coordination and capacity building work. So thanks, Phoebe. We might go to next slide. There are a couple of areas of work that I'll just share with you briefly before I focus on commissioning. So around enhancing the primary care workforce, incorporating digitally assisted services, we have been working hard to try to stabilise the primary care workforce and access rates in our region by focusing on maintaining or increasing the number of GPs and registrars and practice nurses in areas of priority, and monitoring the proportion of general practices that are accepting across the region. We're also working hard as a part of that on rural recruitment, supporting relocations, supporting nurse practitioners in aged care, and building the number of nurse practitioners working in aged care to work alongside aged care homes and GPs. We are monitoring the adoption of virtual care across general practices, allied health and commission services as we continue to implement the strategic plan, and note a very high adoption of telehealth or video-enabled or non-face-to-face services across the region. Thanks, Phoebe. We'll go to next slide. In rural areas, we've been working on a couple of models around piloting different types of services. So our care model pilot in Glen Innes with a multidisciplinary health hub, our small town enhancement model example in Tenterfield, comprehensive workforce frameworks with implementation plans for general practice as well as allied health and primary care nursing. And a focus that we've really had to build and implement in a prioritised way over the past 2 years, which is our sustainability and viability initiative to support the assessment of general practice viability in the first instance, and then the intensive support to those practices at high risk of closure. So that has been very important for us, but also very successful so far. Thanks, Phoebe. We'll go to next slide. When we look at commissioning, there are a few things that I will talk through. We do work very hard to maximise the funding that is going out to services and communities across the region, and we set ourselves some rigorous targets to ensure that we're maximising funding that is going out to the region. We try to maintain low administration overhead within the PHN and benchmark that against other PHNs. We try to make sure that our procurement timeframes are relatively tight and efficient, and we work hard on our commissioning competency as a PHN. We've done a few commissioning competency reviews over the years. The last one in 2024, we've worked very hard on addressing those commissioning competencies, and the team has really progressed in a whole number of ways. Thanks, Phoebe. We'll go to next slide. From the last commissioning competency review, there are 8 key areas that the team has been working on, and they're outlined there on the slide. As we've been doing that, we see within the PHN that commissioning is everyone's business, regardless of role. So we take a whole of organisation approach to commissioning and uplifting the work that we do. We are working towards what we see as a journey towards being a world-class commissioner of services, and that's an ongoing journey for us. The 8 core recommendations sit across the areas of systems, processes, and people that you can see there. Thanks, Phoebe. We'll go to next slide. From our commissioning competency reviews over the years, we've gradually been uplifting our competency at an operational system and people level. 1 year after doing our most recent one, we've been able to demonstrate, I think, a solid uplift across the majority of commissioning domains. That has come about through organisation-wide change and implementation of recommendations. Of the 72 core competencies, we've been able to demonstrate 60 at an established or advanced level. But we do want to continue to improve and develop across all areas of our commissioning work. Some of the things that the team has been able to put in place in the past 12 months have included a fit-for-purpose client record management system, CRM, broader internal focus on our digital technology and systems, new strategic advisory group structure, valuation guide, equity framework, commissioning value for money framework, and a place-based commissioning guide for us working in our commissioning, and they're helping to guide some of our next step developments as well. We have been modifying our tender documents and associated policies to try to streamline processes and have a stronger focus on training and capability development through what we're developing as a primary care commissioning development centre. So there's some of our key areas of work and update. Our commissioning portfolio team works very hard to provide a very seamless, consistent approach to commissioning, and also to continue to connect with service providers, to bring service providers together, to explore innovative practices, stimulate innovative thinking. So there's some of the key areas of work that the team has really been focusing on. At work in bringing service providers together and our team meeting with service providers and hearing from service providers is part, I think, of some development that we're doing around a commissioning relationship matrix. So I might just touch on that next. Thanks, Phoebe. So the team is working on a stronger focus around relationship-based contract management. That's, in essence, a more holistic contract management approach that takes a relationship-based approach while not increasing the reporting burden for providers. It's been something that the team has been very aware of in recent years, is trying to, if anything, reduce the reporting burden. We've heard that message, but make sure that we're trying to measure and hear about the things that are important. There are some key domains around supporting contract monitoring over the next 12 months, and they're on the slide there that you can see. They include performance against contract target and achieving KPI thresholds, data quality, accuracy, and timeliness. so that we can all ensure that we're operating in a timely way. Engagement and communication, seeing relationships are a crucial part of working in commissioning. So this reflects the engagement providers have with the PHN. Service model integrity and quality improvement, ensuring that services are authentic and compliant with specifications and expectations. And where we have sound provider review and quality improvement focus. And then cultural safety and equity, and I'll come back to those a little bit more shortly. So they're some of the key things that we see in the commissioning relationship matrix, I should say, that the team is working on implementing at the moment. Part of the focus on this is around having structured, consistent and ongoing communication between contract holders and the commissioning coordinators, so that we're really capturing performance against those nominated domains. That approach is currently being trialled by the Commonwealth Psychosocial contract holders, and the initial feedback has been really positive, so we're heartened by that so far. I said that I'd come back to cultural safety and equity, and I want to do that now. Thanks, Phoebe. We'll go to the next slide. I mentioned earlier that we have a key purpose, which is to increase equity of access to primary care services. For us, that's something that we want to continue to increasingly focus on in our work with commission services. It means that rather than having a focus where we commission for equality or equal access across the region, we increasingly commission in a way that focuses on equity of access, so that we increasingly look to focus services towards those population groups that need primary care services the most, that have faced the most barriers to accessing primary care from a time, cost, transport or other perspective, and some that are in key locations that are particularly challenging for accessing primary care services. So that is something that I'm asking our commissioning team and our organisation to increasingly focus on, and you will see that coming through the conversations with commission services, and we'll encourage you to continue to look at that as well. The other element around cultural safety and equity, of course, is cultural safety. So Phoebe, we might go to the next slide, thanks. We have been working over time to develop a cultural competency reflection tool. This is a very important part of our journey and development that we see, because we see that across the region, many community groups and communities face disparities in health access and health outcomes. And we want to work to improve access to primary care services. And it's well known that First Nations people have reduced access to healthcare, which directly impacts their health outcomes and our ability as a nation to close the gap. So our PHN is committed to commissioning culturally responsible health and social care services to ensure that we're contributing to improving health outcomes and closing the gap for First Nations people. And we know that embedding cultural safety is an ongoing journey. So we have developed a service-led reflection tool to help services do a few things: reflect on their current practices and services for First Nations clients, track and evaluate their progress over time, guide plans and actions for improving their services' cultural safety, and communicate their progress in culturally safe services delivered to the PHN or with PHN funding. So the tool is built on, well, it's really an extension of work we've been doing internally on a First Nations Health and Wellness Framework that was launched in 2023 and should be used as part of our tender process and then repeated at intervals to encourage reflection and continuous quality improvement as part of the commissioning relationship matrix. As providers work through the 4 domains in the reflection tool, you will identify where you are on the journey towards cultural safety and be guided through key actions that align with beginning the journey, evolving or maturing. So it's an important cultural competency reflection tool that has been developed with the First Nations sector and led by the First Nations sector, which is important for us. We look forward to working with you in over current months around implementation of it. And to what's next in 2026 next. Thanks, Phoebe. We'll go to next slide. So there are a few things. Some of these I've already mentioned. It's an equity framework that's been developed, will be implemented in 2026, and that's part of our journey towards increasing equity of access to primary care services across our region. There's a commissioning value for money assessment, which will become part of our procurement process and allow us to better understand unit price and value in relation to equitable access and service delivery. In that value for money assessment, that is a holistic value for money assessment that looks at, yes, it looks at financial elements and efficiency, but more broadly, it looks at some of the other key elements that really factor in when we look at value for money assessment. Our Primary Care Commissioning Development Centre will continue to grow and support commissioning capability development and help to ensure that providers have the skills and knowledge to actively participate in all aspects of the commissioning cycle, from informing our needs assessments to all other elements like participating in co-design and co-production opportunities, having business sustainability, and supporting evaluation and monitoring of services to ensure that we're working together to demonstrate the benefits, achievements, and impacts of services that we commission. Digital enablement and AI are key challenges globally at the moment, and we will explore opportunities, appropriate and compliant technology solutions that can be implemented to deliver virtual services, increase client choice, and streamline the burden of administration tasks. And income diversification, we continue to look at opportunities to build the funding for primary care services in our region and maximise funding that goes to services and communities in our region. So there are some of the key things that are coming up next. So I think that's the key content that I was going to talk through in this webinar. Thanks, Phoebe. I think that takes us just about to question time. The team is looking to schedule these webinars about every 6 months so that we'll set these up as a regular twice yearly event, but we will be interested in any feedback that you can provide to the team as well. So at this point, I might pause. Thanks to the team for all of that wonderful content, and I will go to questions. Thanks.
Thank you, Richard. Thanks for the presentation. It was wonderful content, and you did cover a lot, so good on you. The first question that we did have come through: what will be happening in the moderate to severe youth mental health space in the Hunter region in the new year?
Thanks, Phoebe, and I will say that the team can jump in on to add to any of my responses as well. One thing to say around youth mental health is that relating to enhanced mental health or complex mental health services, we have been through a redesign process for youth enhanced or youth complex services, and we have released a tender for youth enhanced services. It came on the back of some work that's been done at a national level, partly led by Origin Youth Mental Health Services with their YES principles for youth enhanced services, and some of the changes that have been recommended around access to youth complex or youth enhanced mental health services. So that's come off the back of that national work and our regional co-design that we worked with Chris Shipway on.
Okay, great. Thank you. Next question. What would a compelling case for PHN funding look like for a program we believe would make a meaningful impact?
Well, that's a good question. There are probably a few things to consider within that. One is alignment between identified health needs in our region, the strategic priorities for the PHN, and measurable outcomes and value for money. They're some of the key elements that we look for. The most persuasive proposals generally have a clear line of sight from evidence of the problem to the solution that's being proposed, and are supported by data, community insights, and a plan for evaluation. Some things are really early in their development, and that's okay, as long as there's a clear line of sight to need and evidence. And some have already been piloted and trialled, and that's okay as well. So they can be at different stages of development. It is another thing I will say. Really, a compelling case tells a story that connects community needs, solution design, implementation capability and impact, and does lean into known priority areas. So there's some of the key things that we look for. At the same time, a lot of the time, the PHN simply does not have the funding to be able to implement some new pilots or solutions. Sometimes it may have some available funding, but it may be one-off funding, so it may not be ongoing funding. And so there's some of the, I suppose, the restrictions or limitations that we work around. Also, sometimes there are proposals that come to us that don't fit in within the Commonwealth guidelines for particular programs that we're having to implement. So we might think that they're fantastic ideas, but we may not be able to fund them within the program guidelines that we're working in. I would encourage you to raise new ideas and innovative ways of working with the PHN for consideration.
Can I just add a comment there, Richard? So I think we're currently sitting at about $131 million annually, which is very exciting because it's a lot of services in the community. But the proportion of those funds that are really flexible for us in their use is quite small. However, if it's easier for us to implement a program within a program and within the funding guidelines, so it's a different way of doing something, and you believe that it still meets the requirements of the funding that either you have or you know that that's what the program looks like, that is going to be a lot easier for us than trying to find funding that is currently uncommitted and available for us to use. And as Richard said, it's that one-off nature of things that is really difficult. But we've really seen some gems produced with one-off funding that we've been able to go on with. So, yeah. Right. Thank you.
Thank you. Thank you for Catherine for popping in. Always a pleasure. Next question is a request for an update on mental health strategies and planning.
Sure. At a regional level, one of the key areas of strategic development and planning that PHNs are required to put in place is a joint regional plan with the local health districts or local health networks that are in their region. At the moment, we are just finalising a joint regional plan with Central Coast Local Health District and Hunter New England Local Health District and the PHN, of course, to work jointly in order to improve patient experiences, access and outcomes across the region. It is in its final plan for endorsement and will be released imminently. We continue to look for opportunities otherwise within the region to improve the access to mental health services and integration of mental health services with each other and other parts of the sector. And so that will be an ongoing area of work for us. At a Commonwealth level, the mental health priorities at the moment do have a focus on Medicare mental health clinics or centres and Headspace. So that's probably a very brief answer that I can give at this point.
Thank you. Next question. Interest to know how important outcomes are in the PHN's commissioning strategy. Does the PHN foresee a time where outcomes-based funding will become a reality?
Now, we've always been keen on outcomes-based commissioning and outcomes-based funding, and the team is working to continue to develop that focus on outcomes, and it is central to our PHN's commissioning strategy. Our approach is grounded in understanding community needs, designing solutions that address those needs, and seeking to measure impact through clearly defined outcomes. Activity and output remain necessary for us to effectively ensure accountability, service monitoring, and that services are going towards those communities that we think need them most. But we are progressively shifting towards commissioning that does focus on health outcomes and system improvement. So that is a journey for all of us over time, but an active area of work. We do recognise that outcomes-based funding is an evolving space. We do want to ensure that in implementing outcomes-based commissioning or funding, we're not creating unintended adverse outcomes in doing so. So we do want to do that with robust data systems, shared accountability with providers, and agreement on meaningful and measurable outcomes. So we're actively building the foundations for those at the moment.
Can I make a comment there, Richard, please? So yes, the foundational piece around agreeing and establishing outcomes and collecting the level of outcomes that we think would be useful, we're well advanced in some programs, but I would really suggest that people who are very interested in this, so whoever asked the question or others, if you've got a model that you think might work, we'd be actually quite interested in having a look at that and seeing how that might be something that we could work towards. So really, if there's something that you would like to propose to us, then that would be great.
Thank you. So the next question is TRISP, TRISP funding has allowed PHNs to support preventative and community-led approaches to suicide prevention. Is the PHN network nationally or our PHN specifically going to have an alternative funding stream to support community-led capacity building preventative programs for suicide prevention and mental health?
Thanks. Yes, the TRISP program is targeted regional initiatives for suicide prevention. The focus of that program is towards more community-based and community-led initiatives, but it is funding that is not ongoing, so it's one-off funding. So that's part of the challenge that we have in implementing this style of funding. The suicide prevention space is dynamic at the moment. There are services being funded through New South Wales government as well as through the Commonwealth government. So we're trying as much as we can to maintain visibility and collaboration with the New South Wales government in trying to ensure that the approach is relatively seamless and has minimised duplication, but we definitely await the direction of the Commonwealth and state governments around further suicide prevention funding.
Okay, thank you. The next question is around ITC and IMH commissioning update.
Right, thank you. So the Integrated Teen Care and Indigenous Mental Health programs are both First Nations programs and important ones across the region. The Department of Health, Disability and Ageing has signalled that they are looking to extend current arrangements for a further 12 months to take us through the 25-26 financial year, and has done that very recently. We haven't seen any confirmation of that, but that was communicated in a webinar, I think a couple of weeks ago, that was the intent. The PHN team is currently assessing the implications for current and future ITC providers. Over the past 18 to 24 months, we've been gradually increasing the number of Aboriginal community-controlled health organisations that are contracted by the PHN delivering ITC. So that's been an important progression for us. There is a monthly ITC update provided by the department that people are very welcome to link in with. The PHN is not the decision maker. It is the department making the decisions around the timing and then part of a self-determination led policy.
All right, thank you. Next question, are we aware of any possible funding in the pipeline for adult, severe and complex mental health services, particularly in the more rural spaces in the Hunter Valley?
Yeah, thank you for that. At the moment, the main area of funding increases for adults is in the Medicare mental health program nationally that we're seeing. So otherwise, we await information about new services, both Medicare mental health and others for our region. The Medicare mental health program is seen as a very important one by the current Commonwealth government and a key focus. So that's probably the key area of funding pipeline I can see at the moment.
Sure. Is there any possibility of the current Medicare mental health services receiving full centre funding?
We have two satellite service arrangements in the region at the moment, one on the Central Coast, that's a satellite service split across Gosford and Tuggerah, and the other satellite service is in Muswellbrook. There have been new Medicare mental health centres announced, one being for the Central Coast and the other being for Tamworth and Armidale. We expect to release tenders for those in November, noting that it's the 6th of November now. That will be released, we expect, by the end of November.
Great. Next question, is there a possibility of older persons' mental health funding for rural areas to support the transition and increase psychosocial needs of people transitioning to retirement or coming out of farming?
I'd love to say that there's more funding on the way. I can't say that at the moment. We do receive older persons' mental health funding. However, it's specifically allocated to support residents in residential aged care homes, and is a limited bucket of funding. So while psychosocial funding would be more suitable for addressing the needs of older individuals transitioning out of farming and into retirement, or other parts of the community, that funding stream for us is currently fully allocated. So The group has not been identified as one of our highest priorities in our needs assessment at the moment, but we do continue to reassess key needs in our communities, and we'll continue to look to meet them.
Amazing. Keeping in mind that we have just gone over time, but we are up to our last question. You've done very well. Thank you so much, Richard. Last question. Is there any scope for future tenders to have more detailed reporting or technical requirements required of a contract? Community organisations need this so they can cost the program correctly to ensure they can resource these requests correctly. Additional reporting requirements requested once the contract has been signed off can have a significant impact on the service delivery of the program. Often, when we take on small grants, we have to share data and leadership roles across other programs, and these unknown requests can stretch resources further if we don't have a good picture of what is actually required to be delivered.
Thank you. The short answer is yes, and we get it. Wherever possible, our tenders do include detailed information about the program or service, so organisations can respond with the right information to inform your response. And when we know the reporting requirements up front ourselves, we absolutely look to incorporate them. Where we don't know those requirements, there'll be times when there are new programs or pilot programs and those reporting requirements are outside of our control. And in those cases, we can't include them in the tender because we don't have that information. However, we may be under pressure to move quickly into procurement, even without knowing those reporting requirements. So they're some of the key issues for us at our end, but we absolutely understand the issue. And the team always tries to ensure that that's as clear as can be, as we can make them in those processes. But thank you for raising it.
If I could just add one comment, mindful of the time, Phoebe. Sometimes also we think it's best practice to co-design the reporting requirements with people. So there is an opportunity to have input into that. But again, I would really ask that whoever's asked that specific question, if there's a particular issue that's creating a lot of extra work for you, please reach out to whoever you're working with on the contract or me, and we'll see if what we can do to assist.
And if I can just add in there as well, there's always, any tender always has an opportunity to ask additional questions through the addendum process. So if there's something that's not included in a tender package and you need that information to put in a response, please always feel free to ask it through the addendum process.
Great.
Thank you. Well, that's the end of the questions.
There was just a question about the cultural self-assessment tool that I saw in the chat. Yes, we are literally finalising that as we speak, and we'll have that out. We're really looking to work with some people on testing that to make sure that it works for everyone who needs to be working on it. But it's a really, I think, exciting piece of work that gives you some really practical steps, which people have been asking for. So again, if you would like to be a part of that, please reach out to either Tony Manton or myself and I'll direct you on. Thanks.
Thank you, Catherine.
Thanks, everyone. Really appreciate everyone's attendance and interest. Back to you. Thanks, Phoebe.
Thank you. First and foremost, thank you to Richard for taking the time to speak to all of us. Really great presentation, lots of information, very dense, but it's lunchtime, so we've got the afternoon to process. Catherine and Amanda, thank you for adding your little bits. Always great to have that extra sprinkle of knowledge. And thank you to all of our attendees for spending your lunch break with us, appreciating that we have gone a little over time, but I hope you got as much out of it as I did. I may not see all of you again until before Christmas, so I hope you have a wonderful holiday season and take care of yourselves. Thank you so much.
Thanks, everyone. See you soon.